Today, as I said, we have Dr. Karen Coleman. She is a research scientist too from the Southern California Permanente Medical Group. Dr. Coleman is trained as a behavioral interventionist and has conducted a number of studies for child and adult obesity, as well as promotion of mental health in primary care settings. Most of her work specializes in health equity and the study of patient, provider, and system-level factors that lead to successful intervention implementation. Dr. Coleman also works closely with Kaiser Permanente Southern California Quality Leadership to monitor surgical quality improvement processes. Dr. Coleman is the lead investigator for Southern California in the Mental Health Research Network and maintains one of the largest registries for weight loss surgery in the world. Dr. Coleman, I'm going to pass the controls over to you.
Okay.
And you should have control of the screen now. If anyone has a question during the session, feel free to type it into the box.
So can people see my desktop? Or am I controlling this?
You are controlling the screen that I have.
Oh.
So if you click, you should be able to go on to the next slide.
There we go. Okay. Okay, thank you for the introduction. What I'm going to do is hopefully briefly present a combination of study and actual change in healthcare practice project that we're working on, and then people can ask questions about either the project or maybe just generally mental health care in our healthcare setting, or things related to implementing interventions in our healthcare setting. So the project is called COMPASS, and that stands for Care of Mental, Physical, and Substance Use Syndromes. It's a 3-year initiative funded by the Centers for Medicare and Medicaid, or CMS as they're referred to. And CMS got a bunch of money from the Affordable Health Care Act to fund basically innovative healthcare strategies. They fund the implementation of innovative healthcare strategies that have already been proven efficacious and probably have also gone through some other evidence-based trials, effectiveness trials, in addition to the efficacy randomized trials. And so the project is not supposed to be a research project. It's supposed to be the study of actually implementing healthcare change and putting an innovation into practice. And so there's a research component to this, which is the evaluation of the outcomes, but the actual intervention itself is not a research project. And it's important to make that clear, because when you change practice under the umbrella of research, the adoption of it, in my experience, is very poor. And that's because many healthcare systems view research as something that's extra or something that is not essential. So it was very important that we separate the research component, which was the evaluation, and the actual healthcare changes that we wanted them to make. And essentially, the innovation challenge, which is the name of the grant opportunity, is you know, they want to reduce cost, they want to engage different kinds of providers, they want to create jobs, and you know, actually not start from scratch but leverage existing models to improve patient care. And so these are all things that are actually in the Affordable Health Care Act as goals for anything that tries to change healthcare practice. And the goals are to reduce depression and improve diabetes control, and then decrease utilization of high-cost healthcare services like hospitalizations and emergency care. Let's see. Oops. There we go. These are the different, I'll get to what the intervention actually is in a minute, but these are the partners. So we are the only site in California, and then there's a Kaiser, Colorado but those are the only 2 Kaiser sites. And then the rest of these are kind of physician cooperatives. This is the list. Some of them span an entire state, like the MIC-C here at the top, which is in Michigan. And some of them are very small. Actually, the Kaiser Permanente Colorado program is fairly small, the way that they're implementing it. But they were chosen as systems that did diabetes and depression care differently and had different ways of paying for services, had different networks of doctors, do or may not own or not own their facilities, things like that. They tried to create as much variability as possible. So the model that we are implementing is called the team care model or collaborative care model. It's based on Wagner's chronic care models of disease, and basically it posits that each patient is owned by a team of people. And I know this seems like a no-brainer, but really in our healthcare system in Kaiser, Southern California, patients are owned, quote unquote, by a variety of people, not just the PCP, but there are diabetes care managers, there are depression care managers, there are endocrinologists, psychiatrists, there are all these different people touching the patient, and nobody kind of helps them navigate the system or keeps on top of their care to make sure that when they get a referral to yet another specialist, they actually receive the care they were referred to get. So COMPASS conceptualizes each patient in the program as owned by a team of people. And the primary care team here is just the primary care physician and his or her staff. And they're part of the model, but they're not the critical part of the model. The critical part is a team of people. Members are a psychiatrist, a primary care physician, and then care managers, they're here, who actually deliver and monitor the care of the patients. And every week, that team gets together and reviews cases and tries to brainstorm together about how to care for the patients who have both depression and some other chronic disease. And we've been focusing mostly on diabetes, but there's also coronary artery disease, heart failure, hypertension, things like that. So these are patients in our system that traditionally fall through the cracks. They have a lot of problems, both socially and physically. And then they also suffer from depression, and so they're struggling with that element layered on top of all the other things that they have to deal with. So there's the patient's at the center of this. The patient doesn't really interact with the systematic case review team. The psychiatrist and the primary care physician that are part of the team, they're called expert consultants. They actually don't care for the patients themselves. It's not their patients that are in the program. They just serve as an advisory role. It's really the care managers and the primary care team that have the direct contact with the patients. And these are required treatment components. These are evidence-based elements of collaborative care that have worked. And collaborative care came from the viewpoint of getting depression care into primary care settings. Instead of sending people to psychiatry or behavioral health, you could treat mild to moderate depression in primary care settings to improve other chronic disease outcomes. So they have their systematic case review team that reviews, every new patient that's enrolled in the program is reviewed by this team, and they get started on their treatment plan. Only the patients that are not responding get reviewed after that. They are required to be in treatment. Actually, treatment is a minimum of 6 months followed by 6-month maintenance. And while they're in treatment, they're supposed to have a contact from the care manager either in person or by phone once a month. They evaluate depression symptoms at every contact. They're asked to do treat to target guidelines to really aggressively treat the diabetes and depression, and this is primarily changes in meds, either increases in doses or addition of different medications. And the medications for depression are generally confusing, and it's fairly complex, and so primary care physicians in general are not receiving the kind of training they need to really treat depression to target, to get rid of the symptoms. And that's one thing that COMPASS does for these patients is the care managers are all trained in behavioral activation and problem-solving therapy, and they try to help the patients deal with their, any medication compliance issues they might have, and the psychiatrist and the primary care physician help those care managers with the meds and making sure that meds for depression in particular are managed properly, that people get higher doses, that people get adjuvant therapies, things like that. And then traditionally for these patients, what happens is if they have another serious issue like psychiatry, they need to see a psychiatrist or they need to see an endocrinologist, they're referred and kind of handed off. And in COMPASS, all of those, what we call specialty care in general, are coordinated. The patients are not handed off. They're referred, and then the care managers follow up on those referrals and make sure that they get that referred care. So in Southern California, we have 4 sites. I put this up here because this is the core of the implementation element of this study, is that we allow the sites that are in the program to implement the way that that best fits their current situation. And in Southern California, we layered COMPASS onto an existing depression care management program. And so for these programs that are now in COMPASS, the 4 sites, we have many other sites that just do depression care, but these 4 are the ones that are in COMPASS. They have to learn how to deal with diabetes. And they're not traditionally people who have had a lot of experience with diabetes because they've been doing depression care. And so that's going to come up later as one of the barriers and challenges, is the idea that we didn't start from scratch, which is kind of what CMS wants us to do. But it made it in the long run much more difficult because we had scope of practice concerns and things like that from the people who were already caring for depressed patients. But each site has a little bit different model. Some of them are using advanced practitioners like physician's assistants and nurses, nurse practitioners to administer the care management role. And those people can write prescriptions. They can manage medications. And that makes it much easier if the team can write the prescription or order the prescription and just get the PCP to sign off on it, rather than relying on a PCP to do the ordering and get it in and stuff like that. So most PCPs are pretty comfortable with this process of, looking at it quickly and checking off that they've looked at it and forward it, rather than doing it themselves. There's just one of the things about COMPASS is removing all the steps, all the different hurdles that both the primary care physician has to go through as well as the patient in getting both of these conditions under control. Other sites only have registered nurses and licensed social workers who are doing care management, so they can't do prescriptions, and they have to rely more heavily on the primary care interface in order to get their medications done. Some of the care managers do only depression, and they coordinate diabetes with the diabetes care managers that we've had in place for decades. Others do both conditions. The intent of the model was that one person did both conditions, but again, we are dealing with reality here, and it's very hard to find a person who can do, therapy light, essentially, or behavior change, as well as, changing medications and things for diabetes and depression. So it's tall order. These are just, all 4 sites do something quite different and have different levels of competency within their care managers, which makes it easier sometimes and more difficult in others, depending on who's doing the work. This is the demographics, just to show you, when we first started, the focus was on Medicare and Medicaid patients, because it's the Centers for Medicare and Medicaid, and they wanted us to only enroll those patients. Well, for the most part, the partners in Compass across the nation are dealing with privately insured patients. They don't have a large number of Medicare or Medicaid enrollees, and so it ended up that we could open it up. And so you'll see that there's more commercial patients in our sample than the Medicare and Medicaid. Actually, if you add these together, there's still a little bit more in these subsidized programs. These are generally older adults. Most of the people have an income less than $75,000 a year. Most of them are below, well, about half have a high school education or lower. And most of them are women, which is pretty typical for depression care. And that's one of the challenges, is reaching out to men. We have a majority Hispanic population, which goes with Southern California. Some of the sites have differential race, ethnicity. You can see here one site has almost half their patients are non-Hispanic Black. This site here has a third of their patients need to speak Spanish, and that also creates some challenges with implementation. And they're selected because they're sick, and so a lot of, almost all of them have multiple comorbid conditions. This is a summary of the implementation of the program and also the outcomes. So this first set of columns, these 2 sets of columns are how many patients, the percentage of patients who have a measure. PHQ-9 is the patient health questionnaire, and it's actually the assessment tool we use for depression symptoms. So these are patients who have been in our program for at least 3 months, and this is the percentage of patients who have a depression assessment at least at 3 months or longer. And you can see that we're not at 100%. So we're about 88%. And there's one site that's doing much better in its follow-up, where you have to actually administer this questionnaire either in person or by phone. And so we've been trying to look at that site and create some recommendations for the other sites regarding how they do their practice. And so it's nice to have this kind of comparison, because we can look at implementation. And then they're supposed to be also getting HbA1c in their diabetics. And you can see that, a different site is doing better with this measure. And so we've been talking to them about how do they do that, so we can recommend that to the other sites. And then these 2 columns are the outcomes. And so in these same patients who had an outcome measure, how many of them were below 10 on the patient health questionnaire, which indicates no or very light, very low depressive symptoms or no depression at all. And there's some difference in the the effectiveness of the team. Again, the one that has the best follow-up also has the best outcomes. And then, we're doing less well getting the diabetic HbA1cs under control, and part of that is, reflects a number of things, and we can talk about that. It's super interesting. But again, the people with the best follow-up, or the team with the best follow-up, has the best outcomes. This is care management contact, so we actually monitor the implementation or the outreach of the program. I told you they have to contact their patients at least once every 6 months, or once every month within the 6-month treatment period. And this number reflects having at least one care management contact in the 3 months. So none of the patients, 0%, have a contact every month in any of the sites. And so that's also something that we can reach out to the care managers and talk to them about their programs and why it is that they're not getting a hold of patients every month. And then this is systematic case review, this SCR, which is this weekly review of patient cases. This is also the percentage of patients who had at least one systematic case review in their record. And so all patients, this should be 100%, because all new patients should be reviewed by the team. And you can clearly see that's not the case. And so there are 2 sites that are doing really well with this and a couple of sites that are not. And there are a number of reasons for this being lower, because they're doing it and not recording it, they're not doing it, or they're recording it in such a way that we're not picking it up. And so again, this allows us to go back to the sites and talk with them and try to figure out what reasons explain these disparities in either documentation or implementation of the program as it's intended. These are just linear. It's more of a just a representation of the kind of trend in the outcomes. So these, again, are PHQ-9 scores. You can see the maximum score on a patient health questionnaire is 27. But people who are between 10 and 19 are considered moderately depressed, and people over 19 are considered severely depressed. And many of those patients, although they may be encompassed, they get the majority of their care for their depression in psychiatry, because many of those people probably have suicidal ideation, and it's a little bit out of the scope of these COMPASS care managers to deal with those issues. So you can see, in general, the trend is downward, slowly but surely, working at the HbA1c and the control of their diabetic symptoms. Again, no patient has a contact or a measure in every month of the program, so the kind of jumping around more reflects the number of people in each of these time points than it does weird stuff happening in the treatment setting. But the overall change is very positive. So, and then HbA1c, also another linear trend. You can see that pretty much once they do something at the beginning to modify their meds, they really don't get much more improvement beyond that. And so this is partly due to some internal organizational policies around the measurement of HbA1c and the perception that it doesn't respond to treatment changes very readily, and so we're not getting very good data here for follow-up. And so this pattern may go down a little more if we had more data for these patients, but it seems like an initial change in meds or behavior change strategy makes a difference, and then they kind of plateau. And we do hear this from the care managers, that they're struggling with these patients to keep moving their HbA1cs down. So these are some of the successes that we've had in this program. We have been able to expand the panels of patients that the previous depression care program was able to see. So most of the care managers are carrying about 100 patients for a full-time care manager. That doesn't sound like a lot, but if you think about having to manage depression and diabetes all in a 30-minute, they get about 30 minutes each time they talk to a patient. It's quite labor-intensive, and these models, they probably do not reduce cost in the short term. It's really the longer-term savings that shows the benefit of these programs. So, they're carrying larger patients, but they're still not carrying probably, the amount that our healthcare leadership would like to see. Like, I'm sure they would like to see them have several hundred or 1,000 patients each. We have been able to integrate psychiatry or behavioral health care into decision-making for these patients when before they were siloed and really not part of the primary care process, so it's worked out really well. And we've been able to incorporate social medicine, which is basically, social workers that deal with a variety of issues that some of these patients have. And these are patients who have fallen through the cracks and have not been responsive to outreach. We have, as I said, many care management programs already existing. So we've been able to get patients who would not normally respond to treatment to respond, and so that's very positive. And Southern California actually is one of the better sites in Compass for enrollment and for treatment outcomes, and I think that's partly because the care managers have worked so hard to really pick up these patients and own them as a team within each of their sites. The barriers these are specific to Southern California. Each of the national Compass partners healthcare systems have their own unique challenges. So I've already mentioned that we layered this program onto an existing depression care program, and that's created a number of concerns about scope of practice. If they're a licensed social worker, then they don't feel comfortable treating depression or diabetes or dealing with diabetes medications. If they are primarily an RN who deals with diabetes, they're not terribly comfortable with the depression medications or the depression care. So we've had some challenges trying to help them understand that they can broaden their scope. They are not, the care managers, we have not done a good job of cross-training them in these variety of issues. So if someone is really good with diabetes, we need to really concentrate on depression and vice versa. There's a lot of other people's pet projects that are happening, especially around depression care in primary care settings. It's become a huge deal right now. So we have a lot of other programs that are going on in parallel that do very similar things to Compass, and the finding out about them and then trying to coordinate care, because some of these patients may be in those other programs and we just don't know about it. It's been very challenging. And I mentioned it's expensive short term. Depression is not something that's easily treated with one pill, or patients have generally, they cycle in and out of their symptoms. They need people to help them. It's very much like weight management for years after you've lost the weight or years after you've had a remission in your depression. You need to be monitored, and that's very expensive for organizations like us who have, tens of thousands of diabetics who might be depressed. So it's not a terribly cost-effective model if you just look at the number of patients we treat and the length of time that we have to treat them. So I think that's it.
Okay, Karen, thank you. This is Brian Mittman. So I know with this webinar system, it'll take a while for everyone to be unmuted, but we'll go ahead and start that process. And
Okay.
Arturo, just again, the procedure is the attendees need to input a code in order for you to be able to unmute them. I think it's the audio pin you'll see on your screen.
And so right now I am unmuting the people that have entered an audio pin. Like Dr. Griffin said, if you did not enter an audio pin, you should be receiving it now. If you're at your computer, you should be receiving it now.
Okay, and if we could ask, as you are unmuted, especially those of you who are on their cell phones, if you could mute yourselves. I'm sorry, I'm getting an echo. If you could mute your own phones, that will make it clear for us. Thank you. So, Karen, one question as we wait for others to chime in. One question that I have is the extent to which this sort of approach is applicable to some of the other kinds of care settings that exist. So we see, as we all know, increased establishment and reorganization into accountable care organizations and other forms of consolidation. Within UCLA, which is the system I know best, that is Kaiser and VA, there is a growing primary care network instead of hospitals. So UCLA is evolving into an ACO. Is this the sort of approach that would make sense for that kind of system as well?
Oh, sure. Yeah, I think we all systems have these comorbid patients with depression or anxiety, and so and in fact, for some of these more clinic networks, like the federally qualified health centers and stuff, they don't really have much psychiatry resource, and so they've had to contract out or things like that. So this could potentially help these systems deal with depression rather than having to contract them out to psychiatry and things like that, or have a psychiatrist as part of their, and this goes along with the medical home idea also. So it's a form of medical home, if you wanted to think of it that way, where these patients are getting everything they need by a specialized team that's part of the primary care system.
And are there examples that you're aware of that do involve, contracts with carve-outs where there is an established, division of labor and responsibility? I think that there'd be some difficult negotiations over who's responsible for what and at what point, the handoffs are arranged.
Well, yeah, we do that. Southern California contracts out a lot of its therapy and psychiatry services. So we only have one inpatient facility in all of Southern California, so we often contract that out. And then we contract out a lot of therapy. And so, it is difficult for, and then there's the Medicare, or I'm sorry, the Medi-Cal population don't have behavioral health benefits through us. So they can't even use our services. They have to go to the county. And so we are, that's part of the model, is coordinating that care for the patient, that it's a single person who works with the Department of Social Medicine, for instance, who can help with the interface they have with the county.
Okay, so even within our system, there are plenty of
examples. Oh, yeah. Southern California is one of, we have Kaiser Southern California really, it has a behavioral health care arm to it, but it's fairly minimal. It's mostly oriented around med management by psychiatrists and therapists.
Great. All right, so let's pause for a moment and allow others to add comments, questions. I think most of you should be unmuted by now.
We have a question. So first of all, it says, great presentation, Karen. Compass addresses two common chronic conditions. What do you think about the promise of collaborative care for 3 or more conditions? How would this be received by the care manager?
Well, many of them are doing more than just diabetes and depression. They're also doing coronary artery disease and heart failure. And the reality is that most of these patients have more, they have multiple chronic conditions. Some of them have kidney disease. And again, Compass is about coordination. It's the fact that we have a patient that has 5 different conditions, and each condition has a specialist attached to it, and the primary care physician traditionally just kind of refers them to their specialist if they need it, and they kind of try to handle any lower level issues. Like with depression, they'll give them a prescription for Prozac or something, but they never really manage that prescription. They don't feel comfortable, so they refer them to psychiatry, and they get lost because they're not, nobody, I think of it as an ownership issue, you know, that no one is owning these patients or helping them navigate all these different services. So Compass is ideally suited for patients that have multiple chronic conditions, not just depression. It is focused around any other chronic disease and depression, but theoretically, you know, you could be doing anxiety. You might be able to do bipolar with the coordination of psychiatry, and possibly even schizophrenia and some of the other serious mental illnesses. Although psychiatry, you might want to center Compass as a medical home in psychiatry rather than primary care, because patients with serious mental illness tend to go to their psychiatrist. They're not really coming into primary care. But yeah, it's meant to be flexible and meant to coordinate services rather than handing off the patient.
Other questions, comments from other attendees? And if you are still muted, just remember that you can type into the question box, the chat box. So Karen, as you probably know, there's some similar work underway within VA, you know, specifically focused on depression, tidal waves, and so on. Are you familiar with the VA work, and are there any similarities and differences that you could identify?
So the VA work that I'm familiar with, and I'm not going to remember the program name, but it is primarily focused on integrating depression care into primary care settings. So it's not doing coordination of multiple conditions. Is that what you're talking about?
Yeah, yes, exactly.
Yeah. So, I mean, that's the precursor to Compass was IMPACT, which is another, you know, acronym that I can't remember. But it was only focused on that issue, bringing in depression care into primary care. And so the VA model actually has, my understanding is it has 4 touches with the patients, and the people handling the depression get it under control in that time period, and they handle like 1,000 patients at a time. So that model seems much more efficient than this, but again, you know, they're only dealing with depression. And I haven't seen any published data on the program. I've just seen presentations.
There have been some articles. I'm not sure if anyone else is on the phone who's been involved in the VA work.
There, you know, one of our champions for Compass, a leader in one of the, you know, a leader in various chronic disease initiatives at Southern California, had seen a presentation from the Department of Defense on this model that they were proposing, and he's really excited about it. So we're trying to see, you know, how it may complement Compass and any other kind of multiple chronic disease management programs. Again, that's one of those things that happens, you know, the competing programs. So they may move towards adopting the VA program here, but I'm not sure where that is, where that is in the stages of discussion.
That actually raises another question. That is, you know, you mentioned that the consistency of this approach with, you know, basic PCMH models.
Yeah.
Are there other, you know, approaches that we're aware of that would achieve some of the same goals, but, you know, make use of a different strategy that would be compatible with, you know, the general PCMH concept?
No. I mean, the only ones I know of so far are ones that have tried to integrate depression into primary care, like bring psychiatry and behavioral health into the medical home concept.
Mm-hmm.
So that's, I have not seen a whole, there are patient navigator studies that are similar where they try to interface the patients with the surrounding community and its services. And those patients often have multiple chronic illnesses. So that's another model. It's not a professional, nurse care manager. They're usually lay people that help the patients, but they're not going to make treatment decisions and things like that. They function more as a bridge or a liaison to other services.
So at some point, and this may have already been done, it would be helpful to have some sort of a systematic review, essentially comparing and contrasting the different approaches. Something that we hope the Corey will be funding to examine the range of approaches for improving care transitions, and this is another domain with a number of different innovations and a fair amount of experimentation, and the need to both get a handle on the different models, but also some understanding of how they've been implemented. The adaptations to the models. Are you aware of any of that work, or is that something that you could see happening after Compass is finished?
You mean in terms of doing a systematic review after it's done?
Well, even yes, or even now, based on some of the other versions of this general approach that have been described and attempted.
I think there have been reviews of coordinated collaborative care. There may be a meta-analysis actually. So, for collaborative care, yes, there has been some work already done, and actually as part of the proposal for this project, they did, somewhat of a limited literature review. But it's not looking at all potential models of providing services for patients with multiple chronic illnesses, including depression. So I don't think there's any review out there that's looked at all the possible combinations of that.
Okay, let's pause again. I have a few more questions, but I don't want to monopolize the conversation. Let's pause and see if there are others who are unmuted and would like to chime in. Yes?
There's a hand raised in the audience currently. It's Stephen Jacobson.
Oh.
I'm not sure if Stephen Jacobson might have a question that you'd like to ask. Otherwise, we can just go ahead with the next one. All right, so we'll go on to the next question. This is Karen Han. She asked, are you planning to evaluate concepts, perhaps using some of the existing DII frameworks or methodologies? For example, CFIR.
I don't know what any of those acronyms mean.
Well, that's one where I can help. So CFIR, as we say it, is the Consolidated Framework for Implementation Research. It's something that we use widely within VA. But I think the general question is whether you will attempt to map your sites and data collections, any of the frameworks, and at least one value of doing that I assume underlies the question is the opportunity to provide some generalizable knowledge back to some of the broader questions of implementation, not specifically this model.
So my focus is applying the implementation model constructs to the evaluation or the understanding of Compass. But I'm only one site, and the opportunity for that would be in the potentially in publishing a paper like that. So right now they're working on a list of authors and content and stuff, and implementation's not on their list. So we will get it on their list if possible, and yes, kind of apply the framework to the study or the, I guess, a case study, if nothing else. part of the problem is there are 9 sites, and so each site is supposed to be kind of collecting a general description of how things are implemented, but we aren't, beyond the measures I showed you, which is contacts from the care manager and whether or not they had a systematic case review, we're not collecting implementation data across all sites. So the stories or the application of an implementation framework to the evaluation of this program would have to be done by probably individual site investigators.
And because, as you said, the funding doesn't support that kind of work, it would require an outside grant, I assume.
For across all the sites, yes. So if we were to apply, if we wanted to apply the framework to multiple sites and talk about cross-site differences and things like that, yes, it would have to. The primary focus is on evaluation is a patient survey and cost. So all they care about is hospitalizations and ER and whether we reduce them or not. They don't really care about how it was done.
Yeah, no,
unfortunate. I mean, that's typical, right? So.
Yeah, and then there was some published debate and criticism of that feature characteristic of the CMS Innovation Center and its funding.
Yeah. It's actually a ridiculous grant because we are to implement and show cost savings in 3 years. And if anybody's had any experience with just intervention studies to begin with, let alone system-wide change implementation, it takes you a good 1.5 years just to get off the ground, to get all the parties involved and all your stakeholders and agreement on what we're going to do and what's possible. And so, I mean, we really didn't get off the ground until 1 year into the grant. And then they want to see outcomes on these patients, cost outcomes within a year. Basically, they gave us, it's a 12-month period that the cost elements are supposed to be evaluated for. It's kind of crazy. So, and then if you determine that these interventions didn't reduce costs, so they are costly. So in the short term, they probably won't reduce costs. In fact, costs may go up. And these are patients that aren't getting care in the system. So once they get connected to someone in the system, if they have a problem, they're going to be sent to urgent care or ER because they have contact with someone. So in the short term, you often see increases in utilization with these care management programs for these chronically ill patients that don't get much contact with the system before the program. So it's very challenging to power the entire decision about a program on cost.
And have there been ongoing discussions with CMS about this problem, which I assume is, cuts across all the other projects? Are they talking about providing supplemental funding for long-term follow-up or other ways of ensuring that, the good news that will eventually emerge from many of these can actually be documented?
Yeah, I don't. They have had numerous discussions with CMS, the core group that put in the grant, about the expectations that CMS has for effect sizes and samples and things like that, and the cost outcome. But there's not been any discussion conveyed to the steering committee about future funding for, continued study. Unfortunately, most funding agencies are not that interested in process. They're not interested in funding purely studies on understanding implementation. There's not a whole lot of money out there for that.
Based in part on the erroneous assumption that these programs are like pills, that they're either effective or not, and that all we need to do is measure impact and forget about the contextual factors and the mechanisms and the need for heterogeneity and so on.
Yeah, I mean, it's very, and we don't have really good statistical methods to, I have 4 sites, and they're all doing something slightly different. How do I make a determination about one set of outcomes versus another site's outcomes